I'm Dr. Joseph R.Masi. I'm an infectious disease physician at Maunt Sinai School of Medicine in New York City, and I'm very honored and pleased to speak to you today about MDR-TB and how it may relate to operational research projects. Excuse me while I get the technical side of this down. So the learning objectives for my brief talk today are, one, to understand the principles of operational research as they apply to tuberculosis, to understand the global epidemiology of tuberculosis, to understand the obstacles to diagnosis and therapy which might lead us to design appropriate research projects, and to have operational insight into specific types of studies that would be appropriate. Operational research, I know Dr. Altis had given you a definition. Here's another very simple definition. It is research into strategies and interventions, tools, or knowledge for the purpose of enhancing the quality, coverage, effectiveness, or performance of the health system that's being studied. Applying data from other sources to the real world. The key elements of operational research are what you see here. The health program to be studied should have a well-defined goal. Taking the example of tuberculosis, we could say the cure rate. Obstacles to achieving goals should be identified clearly. Patients lost to follow-up, for example, or those not completing therapy. Research questions should be asked to address these obstacles specifically. Why are patients lost to follow-up, for example? So let's back up a minute and talk about tuberculosis in general and MDR, multi-drug-resistant tuberculosis specifically. This is a quote from Dr. Kumar that was in the current edition of the Journal of Infectious Diseases, a supplement entirely dedicated to tuberculosis this month. Multi-drug-resistant tuberculosis and XDR tuberculosis are spreading globally and now greatly complicate patient management within resource-poor national tuberculosis programs, reducing treatment efficacy and increasing the cost of treatment to the extent that it could bankrupt healthcare systems in tuberculosis endemic areas. There is an urgent need for program and laboratory infrastructure improvement and a dire need for funders, donors, and governments to take this issue seriously, especially in light of the current global economic recession. The statistics on tuberculosis are what you see here. From 2010, there were 8.8 million new cases of tuberculosis in general in the world that were recognized. As you'll see in a moment, not every case is actually recognized. 13% of these occurred among HIV-infected individuals. HIV has, of course, fueled the tuberculosis epidemic. 1.1 million deaths from tuberculosis occurred, which is a staggering number. 350,000 deaths among HIV-infected individuals, and 10 million children were currently orphaned by tuberculosis. So what are the elements of tuberculosis diagnosis and treatment? And if we examine these carefully, where might we target our operational research project? Well, clinical diagnosis of active disease, not always simple. Laboratory diagnosis, out of the reach in many areas of the world. Resistance testing, even more out of the reach. Drug treatment, diagnosis and treatment of latent disease. So how is TB unique? Why are we struggling with this ancient infection? Well, for one thing, there is no adequate point-of-care test for confirmation of tuberculosis. There is poor technology for identifying early active cases, which is the key to containing the global epidemic of tuberculosis. No vaccine has come along, and there are inadequate prevention strategies. There is a need for prolonged therapy, as we know. Difficult therapy to comply with, especially as tuberculosis becomes resistant and the drug regimens become more complicated. There is an uncertain role still for directly observed therapy. It is the gold standard, but where should it be most directly applied? Global political will and the funding to combat tuberculosis has not been very strong, unfortunately. All of these factors have been obstacles to the care and have fueled the epidemic of MDR-TB greatly. So let me show you some maps. This first map is the estimated HIV prevalence among newly diagnosed tuberculosis patients. And as you see, Russia and the United States are roughly in the same category of a relatively low, but still substantial HIV prevalence among tuberculosis patients. This map reflects TB incidence rates in 2010. As you can see, Russia is high. It's in the second highest category of incidence. This is a map showing where HIV testing is conducted most efficiently among HIV-infected individuals. And happily, in Russia, the effectiveness of HIV screening and testing has been very, very good, including among HIV-infected, rather the TB-infected individuals. Countries have applied WHO task force guidelines and have had learning programs to varying degrees. The countries in brown on this slide are the countries that have taken up the World Health Organization's educational efforts, and Russia, of course, is included. So let's talk about drug resistance now. Definitions. MDR-TB, multi-drug resistant tuberculosis, is defined as tuberculosis isolates which are resistant to both isoniazid and to rifampin. XDR-TB is MDR-TB plus resistance to fluoroquinolones and at least one of the three injectable drugs, amikacin, kanamycin, acryomycin. Primary drug resistance means that the isolate was resistant prior to acquisition and prior to therapy. Secondary drug resistance means resistance developed during therapy. The current challenges in addressing MDR-TB. The laboratory facilities for acceptability testing are inadequate in most of the heavily impacted areas of the world. Routine surveillance is not conducted for MDR-TB, so we really don't know the actual number of cases that we're seeing. Treatment and prevention strategies are not consistently applied. How bad is it? Well, in 2004, it was estimated that over 400,000 cases of MDR-TB were currently in treatment. There were 272,000 new cases that year, accounting for 1.1% of all TB cases, and an estimated 43% of global TB cases have had prior treatment, MDR-TB. China, India, and the Russian Federation account for 62% of the multi-drug resistant tuberculosis burden in the world. Germs travel. In the case of tuberculosis, with globalization and the long period between infection and diagnosis of active TB, unfortunately resistant strains make their way around the world very, very quickly. So here we see in this map the distribution of MDR-TB among new cases in the year 2006. The countries in yellow have the highest global distribution. The countries in green have the lowest. China, India, and Russia, as I said, account for 62% of MDR-TB cases in the world, and here we see a map characterizing that. So what are the gaps in care and data? Let's begin to think about research strategies that might help us solve this massive epidemic. Only 7% of MDR-TB cases are actually diagnosed. Only 1% of patients are receiving the recommended treatment regimen. XDR-TB, an even more complicated infection, is increasingly prevalent in many areas of the world, as you can see, including Russia. The complexities in addressing resistant tuberculosis, some of which are here. There are suboptimal control measures specifically for resistant tuberculosis, inadequate infection control within hospitals, prisons, etc. and treatment without direction by drug susceptibility test, which is a prescription for treatment failure. MDR-TB is on the way to becoming XDR-TB, and that happens when we inappropriately use our second-line drugs inadequately. HIV amplification of disease, transmission of disease has been very dramatically demonstrated, particularly in South Africa. And in 2005, only 2% of estimated MDR-TB cases were being treated with appropriate second-line drugs. This is a small sample illustrating some of the incredible problems we have with treatment. This is from the United States between the years 1993 and 2007. As you can see, of these 46 patients, 1/3 only completed therapy, 1/3 died while on therapy, and several others were lost to follow-up or removed from medication for a variety of reasons. So even in areas of the world where resistance testing is available, treatment is extremely difficult. So how does drug resistance spread? As I mentioned, it spreads by two avenues. One is secondary to treatment failure, and the other is through primary infection by resistant strains. Now, when we treat infection with tuberculosis with standard therapy, there is still the possibility for spontaneous mutations to occur to any of our first-line drugs, but that's unusual. When there are drug-resistant mutants, however, and patients are treated with monotherapy with isoniazid, let's say a patient with active disease is given isoniazid alone, and then of course secondary resistance will develop. As you can see these little green eyes. If all three first-line agents are used, even in the presence of isoniazid resistance, there is no breakthrough resistance. Now, once the organism has become resistant to isoniazid, if isoniazid alone is used, then the overgrowth of rifampin resistance occurs when rifampin is added. And here we see, down here, a combination of isoniazid and rifampin resistance developing, all very innocently as sequential monotherapy is added. For managing MDR-TB, patients should receive either hospital-based or domiciliary VOT, directly observed therapy. A single drug should never be added to a failing regimen. When initiating or revising therapy, always attempt to use at least 3 previously unused drugs in which there is documented susceptibility. Sufficient numbers of oral drugs should be started at the beginning of therapy to be sure that there is an adequate regimen when the injectable drug is discontinued after a year or so. Do not limit the regimen to agents if other previously unused drugs that are likely to be active are available. To continue, intermittent therapy should not be used. Regimens including 3 times a week or 2 times a week daily therapy is the rule with MDR-TB. The use of drugs to which there is documented susceptibility, rather documented in vitro resistance, should not be used, even if there appears to be clinical improvement. Serum therapeutic drug level monitoring should at least be considered where available to guide our therapy in this complicated infection. Resistance to rifampin is associated in most cases with cross-resistance to the related drugs, rifabutin and rifampin. Consultation with an expert in the care of drug-resistant tuberculosis should be sought. So here are typical steps in the decision tree in treating multiple drug-resistant tuberculosis. Typically, the first-line drugs, pyridinamide and ethambutol, are begun. A quinolone has been added, all at the same time, and an injectable. Once that is established, we can then consider adding one of the second-line or 2 of the second-line drugs if necessary, cycloserine, ethionamide, PAS. And then finally, the third-line drugs, the newer investigational agents, can be considered if resistance testing guides us in that direction. Imipenem, nasal amoxicillin, clavulanic acid, and macrolide. How should contacts of patients with active MDR-TB be treated? We really don't know. Even guidelines are vague and not well-founded in evidence-based medicine. But these strains do appear to be equally virulent and can spread just as easily as sensitive strains. Tuberculin skin testing seems to be equally effective in identifying patients who have effectively been contacted. And data supporting the suggested treatment regimens are sparse, although typically pyrazinamide and ethambutol are recommended for primary prevention. So are these agents as transmissible as susceptible agents? Contact with patients with multi-drug-resistant TB to the same rate of infection from household contacts that are in the study by colleagues. So let's return to the question of the role of operational research in addressing the tuberculosis and the multi-drug-resistant tuberculosis epidemic. Here are some of the key elements we considered in designing a research strategy. Studies should address obstacles to tuberculosis control. That means identification of new patients, treatment, maintenance and care, identification of contacts. Studies should be planned within the context of an established tuberculosis program, so we can control other variables as we look at a single variable. There should be coordination of operational research activities, so we don't do overlapping studies giving interpretable results. And there should be the possibility, at least, of fast action on the basis of the results. So when we design a research project and develop a research question, we should keep in mind that we're looking for questions to which there will be a clear answer and to which a clear strategy will be run. Now, operational research is particularly well suited to tuberculosis. Delays in diagnosis are inherent because of the natural history of tuberculosis and because of the absence of laboratory capability. So initial diagnosis is a key element in this to attack with an operational research project. Effective treatment requires many things to work well. There has to be adequate laboratory data, availability of the drugs to treatment, easy access to care, including directly assisted therapy. There has to be an application of data from clinical trials that is feasible. And in tuberculosis, unfortunately, much of the clinical trial data is not easy to apply on the real-world setting. And there's a great need for the new real-world strategies to take hold. So some questions to stimulate our thinking about operational research strategies. The primary goal is to improve outcomes. So we may look at case counting and entry into care mechanisms. Obstacles to adherence, either in patient or provider educational deficiencies, the convenience of accessing care, the side effects of treatment and their management. We should look to measure the impact of specific interventions to reduce loss of follow-up of patients. We should develop more patient-friendly educational efforts, remove geographical and logistical obstacles to access when we can, identify side effects that should be addressed when we educate the patient so they don't discontinue therapy unnecessarily, and determine the role of the new diagnostic studies as they come out. Screening for tuberculosis is also a potential subject for operational research. Who should undergo tuberculin skin testing? Who should undergo quantiferon gold testing, more up-to-date means of testing for latent tuberculosis? Is testing being conducted appropriately in our communities and in our health facilities? Can we establish and define what the current strategy should be? Examining the targeting of testing, the efficiency of the program of testing, and identifying areas of concern. Patient loss of follow-up after testing positive, compliance with their preventive therapy, etc. We should evaluate the impact of the testing strategy on outcomes. Remember, everything we do in operational research in tuberculosis should be defined by its impact on treatment outcomes. Latent tuberculosis, is it being treated appropriately when we suspect multi-drug resistant TB in a contact? What is the best regimen? How should chemoprophylaxis of XDR-TB be approached? Are standard guidelines being followed by providers? Are X-rays being used appropriately to diagnose tuberculosis? Are sputum specimens being obtained that are adequate for diagnosis? What is the role for more invasive tests in establishing the diagnosis of tuberculosis promptly? The laboratory elements to this are extensive and they're complex. What is the role of sputum microscopy? How much can we gain from that? That's the single most common means of diagnosis worldwide. Where are culture techniques being used and how effectively? What means of culture is most appropriate and gives us the most accurate and rapid results? What molecular techniques to define resistance early after an organism is isolated are being developed? And how is sensitivity being conducted? How easily accessible it is? And can the diagnostic evaluation, including the laboratory evaluation, be simplified? Treatment strategies in active XDR-TB can also be examined. What laboratory strategy should be employed? Would outcomes improve if resources were devoted primarily to directly observe therapy among these patients, to the exclusion of patients with sensitive TB? What is the optimal duration of treatment? Under what circumstances should surgery, pulmonary lobectomy, be considered? These are several of the newer genetically based laboratory tests which are being utilized in high-resource areas of the world. We can ask ourselves, what is the role for genotypic testing for sensitivity and resistance patterns for rapid results? Directly observed therapy, as I say, is the gold standard for treatment of tuberculosis. However, a recent review by the Cochrane database found that there was insufficient evidence to support its use. This does not mean that it is not the appropriate means of treatment, but this analysis of the current literature is indicative of how difficult it is to apply even the simplest treatment strategies in an evidence-based fashion. I believe directly observed therapy is the best route. What we find here, though, is a failure of the literature to really support that conclusion. With active resistant tuberculosis, how do we define cure? How should patients be followed after treatment? How should contact tracing be handled administratively? Are the usual means of contact tracing appropriate, or should they be stepped up in cases of multi-drug resistant tuberculosis? Should TB skin tests, tuberculin skin tests, be interpreted differently when we're looking for multi-drug resistant TB contact? So let me give you some examples of operational research studies which have been published in recent years on this subject. The principles driving these studies were guided by these. The health program should have well-defined goals. Obstacles to achieving these goals were identified, and research questions were asked that were directly related to outcomes of treatment. Developing an operational research study, here's an example of the thought process we might go through. The setting would be a tuberculosis program. The objective would be to achieve a high cure rate, and 85% treatment success is generally defined as an optimal cure rate. We have to identify the potential constraints blocking us from achieving that cure rate. Our patients lost to follow-up. The research question should identify and trace patients in follow-up through clinic records, active tracing, and identify the reasons for any problems in their follow-up. Answer to the question, the program should seek to reduce the losses to follow-up and improve treatment outcomes. Some things would be a surrogate for improvement in treatment outcome, and some would require demonstrated improvement in treatment outcome. So some examples. This study was kind of interesting. It was published out of Japan a few years ago. It was a study to actually look at the impact of courses like this one, the one you're involved in now, to assess the effectiveness in improving tuberculosis treatment and care. It was conducted in Japan. Methodology was structured questionnaires regarding follow-up activities to 146 participants and a one-time course. They've had a one-day course in tuberculosis management. 62 participants completed the questionnaire. These are providers of care, not patients. Only 28 had developed operational research projects by 3 years later. No papers have been published. The reason for failure to implement operational research projects is lack of time, lack of funds, and disapproval by supervisors. All of these are familiar obstacles to any form of research, but we have to keep these in mind when we design meaningful and doable projects. The conclusion of these authors was that competing job responsibilities and insufficient resources, lack of institutional support, represented substantial barriers to operational research into tuberculosis. Sequential rather than one-time training and ongoing mentoring, in the opinion of these authors, might have been a better approach. This next study looked at the effectiveness of a tuberculosis treatment program at a regional hospital in South Africa. Now, South Africa is the epicenter of extensively drug-resistant tuberculosis today. The location was KwaZulu-Natal province, a very high prevalence region of South Africa, and the design was a retrospective record review and structured and unstructured questionnaires. The results that these authors found, only 66 out of 225 patients, that is 29%, who had positive smears diagnosed in the hospital, actually returned for clinic follow-up. The clinicians did not adhere to the recommended treatment guidelines. 85% of cases were diagnosed without even sputum microscopy. Chest X-rays alone were used in the diagnosis in 45%. Only 18 patients with smear-positive pulmonary TB completed their treatment, and only 11% of the total were cured. So the conclusion by these authors, poor communication and coordination of outpatient referrals led to the majority of patients being lost to follow-up. Inadequate knowledge and understanding by clinicians of the treatment guidelines undermined the implementation of these national diagnostic guidelines. Here's another study. This one was to look at effectiveness of care in a tuberculosis clinic setting. The objective was to assess the needs and perspectives of patients and providers in 2 clinics in India after the introduction of directly observed therapy. The study design was in-depth interviews conducted with 40 patient defaulters, patients who did not complete their treatment, and non-participant observations were included in the study as well. Results. 6.5% and 10% respectively of patients left care before treatment was completed. A lack of convenient clinic times, arrangement for provision of therapy during family emergencies were pointed to as potential obstacles to care. The failure to provide for such complex issues as alcoholism was an embedded obstacle to effective treatment. Poor communication skills and the failure to address drug side effects on the part of providers also a significant gap. So the conclusion, the number of patients not completing therapy might be reduced by more flexible clinic hours, allowances for poor patients to reach clinic, additional training of providers on management of side effects. I'll stop there, and if you have any questions, I'd be happy to try to answer them. Thank you very much for your attention today. Don't see any questions yet. Please write your questions in and I'll answer them. Wait one more moment to see if there are any questions. Nothing's come through so far. I do look forward to seeing everyone later this month